It's my pleasure this week to introduce our speaker, Dr. Connie Van Eeghen. She's assistant professor at the College of Medicine at the University of Vermont. And she works with healthcare providers to improve healthcare management and improve the quality of care as a result. So she's here to share some of her work with us today. So thanks for joining us, Connie, and welcome.
You bet. Emily, thank you so much for having me here. It is so much fun to talk to other people about my work. And I love talking to people who are engaged and thinking about, well, what am I going to do next? Or what's this good for? I love to talk. I also love to answer questions. So if you have an interest or desire in asking a question during my little presentation conversation, the best way to do that is to use the chat function. And although I can't see everybody's faces and won't know if you're like raising your hand or something like that, I sure am interested in knowing what your questions are. And Emily's going to help me know that you have a question. And I also may ask you once in a while to like chat in something of your own in response to a question I have. So just know that that's completely optional. No worries about that. No stress on that at all. First of all, in order to make sure that I can do this well, I'm going to go through the process of figuring out how to share my screen, which you would think by now I know how to do. And I think you are all, Emily, I can see your face. You can see my whole presentation, right?
Right. I see your notes slides. So you'll just have to swap it.
So now let's see if this works. You still see my note slides, don't you?
Yep.
All right. See, I knew that there was more to this than just trying to accomplish a simple screen swap. Let's see, screen 2. How does this look? Better?
Perfect. Yep.
All right. And can you see my cursor when I move around the screen?
Yep.
Oh, great. Then I have a pointer. All right. So let's just pause on this for a moment because what I really want to do is let you know that whoever you are and wherever you're going, you're not alone. That's kind of like one of my thoughts constantly is that we are all kind of trying to figure out who we are and what we care about and how to do it together. Back when I was an undergraduate, I was a double major in economics and philosophy. Okay, so there's a different distance from studying Plato and Milton Friedman and thinking about healthcare, and yet they are connected because everything is really connected. And that's one of the things that I learned is that you never really know where you're going until you get there, but then you turn out to be have this fantastic interest that you love to study and other people like to learn about. So you've got something you can do. I went from my undergraduate degree to starting a master's program in business. And I stopped that because I said, no, it's too soon. I went and was a budget analyst for the city of Chicopee in Massachusetts. Then I went to Virginia Tech down in Virginia, did some budget analysis work down there. Then I went back to school and got my master's in business ad and also in health services management. I decided health services was really important to me and wound up getting a variety of jobs across the country in decision support analysis, doing consulting work on strategic planning, and finally moving with my family. Then I had a family to Vermont. And we decided we liked it so much, we have stayed for 30 years so far. I was working in about 7 different hospitals across the total of my career in Vermont. That included what was once known as Fletcher Allen Healthcare and is now the University of Vermont Medical Center, as well as a critical access hospital in Lamoille County called Copley Health Systems. And then wound up going back to school, getting my doctorate at the age of 50. That's pretty good. And going into research. So there's a long path ahead of you all, and it's going to be so much fun and so exciting, and you're going to get so much out of it. All I can say is you won't know where you're going until you get there. And then you'll look over your shoulder and you'll say, oh, that makes so much sense. Of course, this is what I wanted to do. So that's a little bit about me. Always glad to answer questions about anything, but let's get going on this idea of changing healthcare, as in our healthcare system, to benefit both patients and providers, clinicians of any kind, including the people who are trying to support providers like clinical staff, managers, all the other human resources that go into making healthcare happen. First, I have to politely include the fact that I'm not getting paid to do this, and I have nothing to sell, so you don't have to worry about that. This research was funded in part through a Patient-Centered Outcomes Research Institute Award, and the views, statements, and opinions presented here are those of me and my colleagues and not of the organization, so you can't blame them for what I say. All right, on to the next one. Let's see, what are we talking about today? I have this idea that there is a way for healthcare systems workers, people like you or like you will be, to change the healthcare system. And I am going to help you describe a structured method, a way that is fairly simple, not completely simple, but fairly simple, like you can see it in an outline and talk about it and explain it to help providers and staff redesign and improve primary care. Now, while my work has been focused on primary care, remember I came from a hospital background, and the same structured method works for any healthcare. I have an allergy seasonal allergy thing today. Works for any healthcare environment. So don't feel like I'm leaving you out, because I'm not. I'm including you, but my examples and my research have come from primary care. We're also going to talk about some future directions in high impact primary care services like opioid prescribing and integrated health services, which I did my research on, and just overall increase about how ready can I be, not only to do my work, but to redesign and change healthcare. That's a lot. And I love this image because it reminds me that balance is not something that you can take for granted. We all have to keep our balance in our work lives and our family lives and our personal lives and in the things that we care about most. So these learning objectives are all measured in terms of, we can't overdo it. We have to allow ourselves to be in the healthcare system, appreciate it and change it, and make it work for both providers and patients in the years to come. That's a little about what I hope to accomplish. So now here's a reflection piece. Here is my question. Think for a second, and you don't have to be an expert researcher or anything. You are a person that's studying something about health sciences, and you might have had experience of being a patient yourself or a family member of a patient. So think of that kind of experience, pick out somebody in your mind, and think about what is the impact, whether on providers or patients, what is the impact of our healthcare system on providers, patients, and caregivers, those important people who help patients every day. What is the impact of our healthcare system on these people today? And I really do want to know what you're thinking. There's a chat function somewhere on this process, and I am not sure I can see it, but I know Emily can. And I'm just interested in learning about what you have to think about what you see our healthcare system doing that's affecting providers and patients and caregivers today. I'm going to give you a couple of seconds to think about that.
So I'm happy to read these as they start rolling in. So James says, I think it very monopolized and often more about making money than saving lives.
Yeah, that could really affect how decisions are made.
Access to appointments is strained.
Yep, our system is clogged.
Heard a lot about providers, particularly nurses, being overworked and being responsible for too many patients at once. A lot of research is conducted on only certain groups of people. Overwhelming amounts of stress, being understaffed, to have to have so much out-of-pocket costs. For people without insurance or a credit card, the prices can be devastating. Hospital limits on prescription refills depending on healthcare you can afford. It's expensive and not necessarily accessible for everyone. That is an outstanding list.
And as I kind of suspected, you all know a lot about this already. I'm not surprised because healthcare is like in our minds and featured on our front pages or of our phones as we tag through what's going on in the world today. People are really suffering and stressed, just as it was said. I found the chat, Emily. I see Vermont has, Jonah saying Vermont has limited specialized doctors for patients that have special issues, and that is true as well. So that means the access issue is even stronger for people who are pretty desperately in need of care. So there's a saying that goes around healthcare policy people, which is that our healthcare system isn't a system, it's a quilt. It's a patchwork quilt. And some of the patches on the quilt are not connected as well with the rest of the quilt as we would hope them to be. It's a little threadbare, that's one way to put it. And it's also expensive as well as being threadbare. So it's not serving people necessarily all the time, and it's not very affordable. So it's a combination of things that are really, really challenging for not just patients, but for healthcare providers and the people who love patients and try to give them care every day. And you guys have done an awesome job, by the way, of picking out some of the things I was planning on talking about. So kudos to all of you. Thank you very much for those ideas. So what is the impact? Well, I've broken this down in a couple of ways. And this isn't my work. This is based on the literature. So you can catch up on these if you want to look at them more. But we have some very stress-inducing systems in healthcare. We have increased administrative burdens. So, for example, electronic health record systems, EHR systems, in other words, they are getting burdensome in terms of being able to use electronic health record system and still get the clinical work done that needs to be done. Some are better than others, but all of them have some kind of task shifting onto clinical providers of what they require in order to operate. There's a lot of paperwork. There's a lot of requirements. You need permissions. You need prior authorizations. In order to be able to get work done, you have to go through a certain amount of administrative requirements to do the clinical work that you were trained to do. And you have to document your work. Of course, that's important, but you also have to measure your work these days in something called quality metrics, because that's what insurers and payers now are using to determine whether or not you should get paid for the work that you did. There are some unintended pandemic-related burdens as well. We have inadequate testing services, or we have had inadequate testing services at times. This is particularly true for those people with specialized needs, but even with people with more general needs, there have been queues and waitings. Think about some of the trips you have made to the lab or to get a test, and it's kind of difficult. Limited treatment options, insufficient personal protective equipment and other medical supplies, extended workloads. So this is a stressful system to work in, say nothing of being a patient in. And what we know is that over time, the role has shifted and the work burden has moved. So this is a 2021 survey. So this was during the pandemic or the beginning of the pandemic. We're still moving from pandemic to endemic, but let's just say this is part of the pandemic data that we have, a survey of about 3,000 physicians and nurses around the world. And what they've noticed as they were surveyed was that physicians have reported 75% of them that their roles have changed in the past 10 years. 63% say their roles have gotten worse, more burdensome, more difficult. Nurses, 85% have noted changes, and 60% have said it's gotten worse. All right, that doesn't sound very uplifting. That must be really hard to deliver care when you're feeling like things are getting worse. Furthermore, there's a shift in the workload and the work-life balance. 34% of US clinicians, so US clinicians, you're going to be part of that group if you're not part of that group already, said that they work more now than they did 5 years ago. 51% of doctors said they had a good work-life balance. That means about half said they did not have a good work-life balance. And 66% of nurses indicated a good work-life balance. So there's some shifting that turns out to make it a little more difficult to have the kind of life that you want to have as a doctor or a nurse or a clinician. Healthcare workers, this is a really sad one. Healthcare workers make up 50% of all workplace violence victims in the United States. So you're in a dangerous field, depending upon your actual role. And 45% of US doctors and almost as many percentage-wise US nurses report spending enough time with patients to deliver good care. In other words, more than half are not spending enough time with patients to deliver good care. So what is our healthcare system doing to our providers? It's adding to their roles and it's adding to their work burdens. What else? Well, there's COVID. Okay, so we think about COVID and what kind of effect it's had. First of all, there's the virus itself. We didn't remember when this was new to us. We were not sure just exactly how deadly this was. Now we know that it is a dangerous virus and that you can do something about it, but it's still not really clear about some of those longer term outcomes about what that means. We've had variation in how easy it was to get testing and treatment, something that you all just noted a few minutes ago. Unfamiliar imposition of public health measures. What are we supposed to do? How are we supposed to do it? Infringement of personal freedoms. Do I have a choice in how I get treated and during this period of being in a pandemic? Unexpected and growing financial losses. Healthcare systems began to lose even more money than they had before. And this kind of leads to how is it that we have waiting lines when we have organizations that can't afford to stay in business? And we have conflicting messages from authorities. So these are all stressors placed on our healthcare organizations and providers. But in addition to that, there are the stressors that the patients bear and that they bring with them. Insecurity, confusion, emotional isolation, stigma if they were at that point early in the pandemic identified as having COVID, economic loss, work and school closures, distress, an increase in psychiatric conditions, excessive substance use, and not complying with home confinement and vaccination public health laws because they didn't believe it or they just couldn't do it in order to be able to take care of themselves and their families. And then there's the provider burdens. So it's a time of emotional distress, risk of exposure. Am I going to get sick because I'm trying to take care of people who are sick? Concerns about infecting others, concerns about caring for loved ones, concerns about shortages of equipment, longer working hours, and just being involved in ethically fraught resource decisions. Who gets what and when? How do we decide? How, if we've got a limited number of treatment beds or ventilators or whatever we thought we needed, how do we make decisions about that? So clearly the environment recently has gotten more stressful. And we've seen that in how physicians and nurses and other healthcare workers talk about what their lives are like and what their work roles are like. Then we have another background issue, and this is something somebody already mentioned, so thank you for doing that. There's something called burnout, that feeling you get in your stomach when you just feel like you can't do this anymore, that you are done, you are just exhausted, you are burned out. Before the pandemic, this was already associated with lower work satisfaction and greater emotional distress, reduced productivity, high job turnover, and a negative overall effect on the quality of care. In other words, it isn't just the professional that's being affected, it's the patient care system as well. Burnout is different for different kinds of providers. They can be either low or high, depending upon contact and engagement with the environment. For primary care providers, it turns out to be higher at the 89% range. And for physicians who are hospital residents, they too suffer from higher rates of burnout than the general provider population. Physician suicide rates more than double of that of the general population, and even higher for female physicians. So there is a huge impact on burnout. And again, you probably saw these stories intensify during COVID about the reports from the providers who said, I just can't do this. So there's plenty of stress by our system placed on providers and patients and caregivers. That's like probably not that contestable. What we need to figure out is, how do we make changes? And there's plenty of incentives just from that list. Look, we've got stress-inducing systems. We've got changes in work and role burden. There's more needs. There's COVID. There's long COVID. There's post-COVID. There's burnout. So there's plenty of incentive to change the system. But there's also plenty of barriers to change the system. And in fact, they are the same thing. If I am stressed out because of the system, I don't have the energy to figure out how to make a change. I am trapped. I am stuck. I don't know how to make changes in my role and work burden, and my role and work burden are getting heavier. So it's less likely I'm going to be able to figure out how to make a change. There's more needs due to COVID and the aftermath of COVID. And then, of course, there's burnout. So how am I going to make these changes if those are, while they might incentivize me in some ways as a provider or healthcare worker, they might also produce barriers for me because I just can't stand what I'm facing in terms of the stresses caused by the system to be able to figure out how to make a change. And that's what we wanted to figure out is how can you make a change in this stressful system? So now that's the last bad news slide, I promise, kind of like now it gets better. So now we're going to talk about something that's a little more fun to think about, which is how do you make change? So take a look at this picture. I don't know if anybody knows what it is. Come on, you Vermonters, you probably all do. Sometimes when I talk about this topic, people go, what the heck is that? Something for outer space? Anybody want to grab the chat and tell me what that is? I'll give you about 5 seconds. Oh, somebody got it. Ooh, a couple people. Yes, you got it. All right, that's a fiddlehead, which is the precursor to a fern. Yes, the other people, great, yes. So that is this delicate little thing that grows in the spring that later on becomes this indestructible fern that you can't pull out of your garden if you try with both hands. But at the very beginning, it looks like this, like the head at the top of a violin or a fiddle. And it is already designed, it is already created as it's slowly uncurling to become exactly the thing it is supposed to become. Now, you all took biology, I'm sure of that. You already knew this. But we've extrapolated from this idea, and a scholar named Hannah, back many years ago, said, every system is perfectly designed. Every system is perfectly designed to generate exactly the outcomes it gets. So what are we seeing right now? Stress, burnout, people overburdened, all right? Patients waiting in lines, people not being able to access the care that they need. That is a system perfectly designed to deliver exactly those outcomes. That's like you're saying, well, who the heck designed that system? And the answer is nobody designed it. It was created by many, many different people over a long period of time. It would be a fun lecture, but not this one. But the outcome was that we have a system that performs exactly the way it is made to perform, because that is how it was intentionally or unintentionally designed. So that means if we want to change our outcomes, we have to change the system. We can't just say, oh, we need more providers. Oh, we need to have longer hours. We can't respond to the symptoms of what we see. We have to understand what's happening in the system and understand what causes the system to behave that way in order to change it. Well, how the heck is anybody who's on the front line of healthcare going to change the system? And it turns out there is a way. It is not necessarily about redesigning US healthcare policy, but it is redesigning how it is we organize the services that we have right in front of us that we deliver every day, and how they organize around the needs of the patient and the capacity of the provider to generate the care that is needed. So I'm going to tell you now what this whole presentation is about in a single slide. So it's kind of like, if you can remember the slide, actually, I want you to remember the fiddleheads. Remember those fiddleheads. They're really good. Every system is designed to produce exactly the change, the outcomes that it gets. But this slide says change is possible. It's not just essential to changing your system outcomes. It is also possible. So here's what my idea is. We face many challenges, many challenges in helping patients, communities, and ourselves enjoy a good health. We are not going to run out of challenges ever in my lifetime, in your lifetime, maybe your children and grandchildren as well. But we will face those. And addressing those challenges is going to require new strategies in patient care. We have to do things differently. And this won't be one change. This will be many, many changes because we have many, many challenges, right? So we are going to be changing the healthcare system a piece at a time over time. We will have to do things differently, and we will change those different things on a regular basis. I remember as I was been a healthcare administrator for over 2 decades, and I was always saying to people, this will be the last change I ask you to make. And it turned out to be a complete lie every time I said that. There will never be an end to the changes we need to make. We need to learn how to be good at changing. And that's one of the things we need to be able to think about. How do you do that? Being good at changing. So my proposal is that if we had a structured team-based method, kind of like a recipe, to analyze our practice workflow, what is it we're doing every day, and to figure out how to easily integrate new strategies with the everyday work of providers and their staff, we can change anything all the time. So it's kind of like if you were driving a car, let's put you in a Tesla. You all like Teslas, I hope. And you wanted to change some aspect of that car while you're driving it down the road. Some engineer somewhere would be able to converse with you about what that change should be while you're driving down the road, program that change, and have it work for you in your car as you're driving down the road. I don't know if we can do it quite that easily in healthcare, but it's certainly a lovely thought for a Tesla. But what we're thinking about right now is how do we create a recipe for change that works for everybody in healthcare that can be used for the everyday stuff that drives people crazy? All right. So if that's the goal, a structured team-based method, let's talk a little bit more about what that structured method looks like. And we actually have a world full of structured methods of change. There isn't a creature in nature that hasn't had to figure out how to adapt beautifully and quickly to whatever slender piece of environment it finds itself in order to do the work it needs to do. When we as human beings work in teams in healthcare, we're a little bit more encumbered because we have rules and regulations, we have evidence-based practice, we have policies, all of those are important and good. But that doesn't mean that we can't change. If we have an agreed upon approach, this piece right here for solving organizational problems or creating new solutions, then we can slowly and systematically make any change we need and be as nimble as we have to be in order to meet the challenges of today before they become tomorrow's challenges as well. And it's a quite simple recipe with a couple of extra pieces to it. I think I want to do like a little station break here. I love this so much. Plus I see a chat. Change is constant. That is totally true. This particular photograph was taken by someone who is a patient caregiver of a patient with a chronic illness who joined a research team thinking that it was not possible to participate in research as a chronically ill patient. And it is a testament to both the patient and her caregiver, her husband, that they not only participated in research and helped us to solve problems using the structured method, but they took beautiful pictures of their environment around their house up in Hyde Park in Vermont and contributed those pictures to presentations like this so we kind of get our message across. So hats off to Richard and Paula Reynolds for helping us do this. All right, that was my station break. So there's 3 steps: planning, design or redesign. Some things need to be like they've been designed, but they need to be changed a bit, and implementation. What do you do once you've figured out what you think you need to do? Sounds simple, right? It's like, well, like, is that like magical? Doesn't everybody do that? Doesn't everybody know that? And the question is people don't actually do it all together. They have different ideas at different times. And so the starting point for any solving any problem is not the solution. Like, let's fix this now. Let's open the gates. Let's have, longer office hours. Let's work on weekends. Let's hire more people. Hard to do these days. But instead, we're going to take a very thoughtful approach, starting with this idea of planning. So planning steps, and I put them over here on the right in a different color so they're easy to pick out. It is essential that anybody who's trying to change our healthcare system at the ground floor has a shared vision with their team on exactly what is the outcome that we're trying to get. Drawing a picture of it, writing a description of it, creating creating a slogan around it. I don't care what it looks like. It has to be able to capture what everybody is seeing in their heads. So everybody is sharing the same theoretical outcome that they could possibly achieve doing this healthcare system change. In addition, and I want to say that this is part of your roles as a scientist, is collecting the data necessary to be able to say, here's what it looks like right now. Right now, we're accomplishing this. This is how we measure it. So that later on, we can say, well, did we make a difference? Did we make a change? You'll know because you'll have a baseline to compare it to. And you have to say, what is the scope of our change? We might have this fabulous vision, but are we allowed to work with all patients? Can we use any service? Can we identify resources that we want to change, like physical space or the electronic health record? What are the limits of our change? So we need to know our vision. We need to know how is it going right now for everybody? And we need to know what our limits are. What can we and what can't we change? That's planning. Sometimes that takes one meeting, one day. Sometimes it takes 1 month, and sometimes it takes 3. It depends on who the team is and what it is they're trying to accomplish, but it is critical. All right, the second step of this recipe, planning being the first, we're now on design or redesign. You have to go and understand, and I mean go to that place where this thing is a problem and understand what is really happening. We think we know, it's written in the policy. I was educated this way. I went to school, I know how this works. But when everybody gets around the table and shares what they see is really working, then some of the issues and problems that need to be considered come to light. And some of the wasteful steps and some of the missed opportunities become really evident. So first we go and we look, and then we say, so what's working well and what's not working well? Let's not throw everybody out. It's not necessarily the case that we need to. Maybe we do. Maybe we need to do a complete design, but maybe we just need to redesign some steps. And then what are the things that are known to be true about how this can work differently? Every healthcare system works a little differently. And there are so many good solutions that have been created out there that just asking around a little bit, looking at the literature, good source, or looking at the standards that are there for evidence-based care are extremely helpful in finding out what is available to us in terms of an alternative. We then say, what is it we want to look like in the future? What is our future going to be? How can we do this differently based on these different strategies or alternatives? And then what are we going to actually do? What can we accomplish? Who does it? What is it they do? And when do they do it? So planning, know what we're supposed to do. We got boundaries, we got measures, design. What is it actually that's happening on the front line? What is it that we could do differently? How would we make that happen? And who's going to do it by when? Seems pretty simple. And the third step is, ta-da, implementation, like you got to carry it out or it doesn't count. And interestingly, there are health systems that can do a great job planning and design and actually can't execute the design. So this step becomes really important because if you don't execute it, then you really can't expect to see a change, right? Every system produces exactly the results it was designed to produce. So better change the system if you want a different outcome. Implement the plan. Often that's done by rapid cycle testing, where in little frequently meeting teams, plan, what are we doing next? What's the next step? Do it. Okay, we'll do it for a week. What did we do? Did it work? And then we decide, act. We decide, do we adopt that? Do we change a little bit and adapt it? Or do we abandon it and try something else? Again and again and again until we feel like, yep, we got it right. We evaluate it, step back, look at this. Do we like this? Is this working for everybody, including our stakeholders, and communicate effectively so that everybody gets a sense of what is it we're supposed to be doing. So that's it. That is the structured method in 3 simple steps broken down into a couple of more that can be done elaborately with special tools. There are whole management frameworks that do this. There's many great ways to get this done, but they all use the same steps. And I've just kind of laid them out because if you don't all have a shared set of steps, then you are all acting differently and it doesn't really matter because you'll all cancel each other out. So using a structured, consistent method that involves planning, design, and implementation is pretty important. So what does that actually look like? This is that same list of steps, And what we did in our research work was we developed toolkits that laid out the structured method and supported them with quality improvement coaches in order for practices on the front line. Remember, these are primary care practices we were primarily working with, so that they can make changes to their healthcare system more easily. These toolkits are actually published now. One is improving care for patients with chronic pain while reducing their opioid prescribing. And that's a toolkit that sits out on the University of Medicine. This is the Area Health Education Committee toolkit section. And this one, integrating behavioral health and primary care. In other words, moving behavioral health services and primary care into the same office to improve outcomes for patients with multiple chronic conditions. And that's living out on a Google site called IBHPC/home. And both of those are free to access and look at if you wanted to see some examples of those. Also, I can share those links in the chat with you if that turns out to be interesting to do. But for right now, what I'd like to do, you check my time a little bit, doing great, is I want to talk about what that looks like when you're actually conducting research. So we're going to go dipping into my research at this point. Sounds like this is good time to do that. All right. So the first one, remember, there are two different toolkits, and these were both tested out. One was this, the topic was, how do you make changes in opioid prescribing? So just a little background about the kind of study this was. This was a mixed methods, meaning that it was a combination of quantitative numerical data and qualitative data, verbal narrative data, combined together in a prospective, moving forward over time, interventional case study of 10 ambulatory practices. These were in Vermont. Practices that could be as small as 2 providers to as large as 12 providers, providers being the front line that connects directly with the patient as an independent licensed provider. Provider ages ranged broadly and were from 5 different Vermont counties. 9 were in primary care. 1 was in ambulatory care with an orthopedic specialty. So we ran this experiment with just to see if it made a difference for the one that was not primary care. And what we did was we paired pre and post-intervention surveys. We surveyed everybody ahead of time, and we surveyed them again afterwards, both providers and their office staff. And we got about a 73% response rate, which is pretty good for a open volunteer study across the state of Vermont. Now, why opioids? Well, I think you may have seen in a variety of newspapers or websites or whatever, that there's an opioid-related death crisis in our country. This graph right here talks about how providers are prescribing opioids, and this is prescribing rate of 100 milligrams per person. So this is looking at over this period of time, in a year's time, these rates were going up. We were prescribing more and more and more. And then people were like, wait a second, this isn't a good thing. There are people that are getting hurt. So prescribing began to come down, and it's come down to below where it was in 2006. And it has begun to plateau a bit in the state of Vermont data. This is annual overall. So it's a key issue here. This one in particular is showing high dosage, which is more than 90 milligrams a day. And those are slowly coming down as well, but it's slow. It's like a gradual change. And what's happening on the other side of the screen is that we have a rise in opioid overdose deaths. Now, originally, we were looking at this black line, this commonly prescribed opioids. Purple line of commonly prescribed opioids, which took a dip for a while and then went back up again. While this was going down, the deaths due to heroin began to go up. As heroin became less available, other synthetic opioids came up. But they are all going up, and they all require our attention in terms of how do we change the access and use of opioids in our general public, because many of these opioids, if they are not the cause of death that are being prescribed, they are the beginning of a habit of using opioids that then translates into other sources. So it's important. It's got real consequences in terms of people's lives and their quality of life. So what we started with was, remember I said in the process, you have to have a planning piece, you have to have a design piece. In the design piece, you have to have strategies. What can you do differently? And so as practices use the toolkit and they go from planning to design, they discover that they have choices. They need to pick the strategies that work best for them. And sometimes these are practice-wide strategies, like everybody in the practice has to do them. And sometimes they are individual to a provider. I need to do this. This will be better for my patients. So what we have here in terms of strategies, and these are 3 out of 7, there's quite a few strategies, but these were the most popular and the most important in our research. A consistent approach. We don't differentiate the patient I know so well, I'm sure she's not abusing opioids, from this patient I don't know very well, and it looks kind of sketchy, and maybe I should really run every single test I can on this person before I prescribe opioids. No, a simple, consistent approach for everybody, just like universal precautions. We are going to make sure that we don't miss anybody, that we don't make any assumptions, that we don't have any biases, that we're equitable. We are going to use a consistent approach across the practice. Furthermore, we're going to use a team approach. We're going to involve everybody in the practice, from the front line, front desk scheduling person, to the triage nurse, to the person who rooms the patient, to the provider, to the person who does the follow-up scheduling appointment, to the person who makes a phone call later on to say, is this working for you? Are you okay? Everybody's going to be involved in this. And we're going to ask our patients to come in regularly for chronic pain management. We're not going to just wait for them to have pain or run out of a prescription. We're going to get ahead of it by saying, come in and see us regularly. Your chronic pain is important, and we need to manage it together. Those are examples of practice-wide strategies. So remember, this is part of a toolkit, and it's in part of the redesign and design section. And these are things people can say, should we be doing this? Are we doing this? Could we do a better job? What would be different if we did this? Similarly, some strategies are for individual people. So the PDMP is the prescription data monitoring program that every pharmacy enters data in for any prescription that is restricted or special. So all opioid prescriptions get entered in this database, and providers can check that database to say, are my patients getting prescriptions from other sources? Are they picking up their prescriptions? How is this working for them? So they've got a statewide database, which is also informed by other states' databases, to say, how is this working for you? A provider can also conduct initial risk assessment before I give you this opioid prescription and have you sign on the dotted line that you'll do it well. Let's make sure that this is a good choice for you. A prescriber can also prescribe in multiples of 7 days, which means that instead of prescribing every 30 days, because 30 is a number kind of like a month, prescribe in every 28 days. Doesn't matter if it's February or not. Every 28 days, and your prescription will run out on a day that your prescriber is in the office. So any need for more prescriptions gets connected with your own personal provider. And conducting ongoing risk assessments. Just because you were okay once doesn't mean you're always okay. Let's make sure you're doing all right with this. So these are more examples. There are others that I'm not going to go into right now, but what I want to do is say, you don't have to pick many to make a difference. So I'm going to show you an example of what the workbook process, the design process, looks like when you pick just one of these strategies. And the strategy we're going to pick is this one: regular visits for chronic pain management. If we just make that one change, out of all these different things we could do, if we make that one change, what difference will that make? So here's what it looks like when you're doing a design change. Okay, you're sitting over lunch, you're eating your lunch, catching up with your colleagues, and you're saying, so help me think this through. What exactly are we doing for prescribing medications right now, especially opioid medications? And it turns out to be very simple in many cases. The patient telephones for a refill. Hello, I'm running out. Please refill my prescription. That becomes a message. The message causes the providers and the staff to check the patient record, ask questions, conference together. Sometimes they have to call the patient back and get more information. Sometimes the patient's been waiting for a while because it's a busy practice. And so then they call again. So now there's a new request for a refill, and then the providers and staff check. And this can go around once or twice. And then eventually some kind of fix is like, okay, let's issue the prescription, or if this doesn't look like the right thing, we can schedule a visit. It's okay, it'll work out. That is often the answer I received as I was helping practices think about, well, how is it that our actual prescribing system works? Well, how does that look with a chronic pain visit? Okay, so what changes? What's the big deal? Why would this be different? And the answer that I can tell you is that it looks radically different. Oops. So here we go, chronic pain management visit strategy 3. We have you down for a regularly scheduled visit for chronic pain management. You get a prescription for either 30 days or for 3 months, but it's really going to be in groups of 28 days because that's how we make sure that your refill doesn't happen on a weekend. We make that long-term plan with you, and you have instructions that if anything changes in your need for medication, you're going to call us ahead of time. But otherwise, you're on that plan for 3 months. And if you do need to make a phone call, well, first of all, you're going to need to make fewer phone calls because now you have a plan because you know you're going to be seen again before your prescription runs out. And if something has happened that's really dire, then you're going to get a new visit scheduled. But there won't be any of this circulating work of, oh, where's the message? I lost the message. Okay, they called back. Okay, I got it. I looked it up in the chart. I'm not sure where that meant. Skip all of that. There's a plan. Stay on the plan. Unless something really important happens, then come in and we'll give you a new visit. Period. End of the conversation. No over the phone refills. It takes out a tremendous amount of work, and it ensures that the patient is safe and that the providers know that they're doing good work. Just that little change. So what does that mean overall? I mean, we had practice after practice doing their own version of this. Not everybody picked the same kind of idea. They had to do it based on what their needs were. So in this particular study, we could see that we asked patients before and after. Remember, there was a pre-post survey. So the blue is where they were at the beginning of before the study happened. Red was afterwards. So provider satisfaction. Look at that. Staff satisfaction. Very good. Clearer policies. Knowing who your opioid patients were. This is a roster that tells you these are the patients that you're helping that need those every 3-month chronic pain management visits. Increased use of agreements, making sure the patients are in sync with the providers so that they both know, yes, we agree. This is what we're doing with this plan to come in every 3 months, for example. Providers' feeling of confidence increased. Providers' feeling of confidence in drug testing increased. Feeling of confidence in prescribing increased, and using the database as well. Everything, every single indicator we could measure said this one change, whatever it was that a practice did, changed their health system and changed the outcomes and made their lives less crazy and their patients more healthy and more able to get the care that they need. 1 or 2 changes, depending upon how many picked. So does that prove anything? Well, it proves something for these 10, 9 primary care practices, 1 orthopedic practice, in that they believe that they could now manage the system more easily. So when we go back to that, remember I said there's one slide that's going to be our main slide. So if we go back to this slide, yes, there are many challenges in helping patients and communities enjoy good health. For example, there's the growth of the opioid use disorder and overdose fatalities. That is a serious challenge. We need to pay attention to that. Can we do something about it? Yes. We've got a variety of practice-wide and provider-specific strategies. How you use them is up to you, which ones you use. But if you pick one, for example, chronic pain management visits, you can change the outcomes for your patients and for yourselves, for providers, for staff, for people working in the healthcare system. So again, when it's not a proof so much as it is a proof of concept, but we see and in the next study that I'll show you how we worked with many more practices, having a systematic approach to structured change is something that can make a difference in the lives of patients and in the lives of providers. Okay, so that was all about opioids and the opioid use disorder and what can be done to help that not be the problem that it is in the same way. We picked a different example for the next one. This is about integrating behavioral health care. So this is especially for patients with those specialized needs. Remember, somebody mentioned, for example, rheumatoid arthritis. There are some really debilitating chronic diseases, and they come in multiples. Diabetes is a long-term chronic illness, but it doesn't necessarily come alone. It could come with diabetes, it can come with a heart condition, or it can come with depression, or it can come with anxiety, or it can come in a combination of a number of things. So trying to care for someone who has a chronic illness is a really difficult challenge just off the starting block, without the healthcare system being difficult to work in. And what we proposed was that if we brought behavioral health workers into primary care, like a social worker or a psychologist or a psychiatrist, and said, work as part of the primary healthcare team. You might have to change what you're doing. And in fact, you always do have to change what you're doing when you're working with a team. But you can, by what's called co-locating these behavioral health providers into integrated primary care practices, we can change how patients are cared for. But it's not easy. There's a long history of, we've got medicine over here, and we've got psychology, psychiatry, and behavioral health over there, and substance abuse is even over there a little bit farther, and it's not really built to be put together. These are not car parts that automatically work together. They need some retooling and redesigning in order to work. How they schedule patients, how they connect with each other and consult on patients, how they work with patients in group settings, how everything has to be rethought. How do we actually integrate behavioral health services into primary care? So you can do it by just dropping a behavioral health provider behind a desk and saying, sit there and we'll send you patients when we need to. But actually, integration would mean integrating at the system level, so that scheduling and assessments and working with the team is built into the job, as well as actually seeing the patient. So we did a randomized control trial, that's the RCT part, of primary care practices for adults with chronic medical and behavioral concerns. They were going to need both kinds of care. We created a toolkit to support practice level redesign, sort of what we were talking about before, to fully incorporate on-site behavioral health services. And we compared this to on-site behavioral health provider practices that didn't have the toolkit. So does this toolkit make a difference or not? Can you use this structured method actually work or not? And our outcomes were, well, did the patients get any better? And did the practices get more integrated? Did they improve what we had an integration score? And the settings of these practices were 42 family practice and internal medicine in 13 states, including Alaska and Hawaii. They ranged from small, medium, and large clinics, academic, not academic, safety net clinics, non-safety net clinics, all kinds of clinics throughout this. And again, I'm going to start with the strategies, that piece in the middle of the design element, excuse me, of the workbook. And I'm going to say there are many, many behavioral health care integration strategies. So I'm picking some categories and giving you an example of each. So one major category is coordinating access to behavioral health providers. What could that mean? Well, for example, you could schedule the visit length to meet the patient need. In the past, many behavioral health providers, like psychologists, are trained to do their work in 50-minute intervals. That's how long a patient visit is. But in primary care patients can be seen in as little as 10 minutes for a healthcare visit, maybe 15, never more than 20, unless it's like an annual wellness checkup. So how much behavioral healthcare does a patient need? That might depend on what the patient actual need is, not some arbitrarily predefined, here's the length of a visit, it's supposed to be 50 minutes. So that affects assessment, that affects how you collect history and background information, affects where you document, because now your behavioral health provider is going to need to document into the shared medical record system if in fact they're going to be meeting for briefer times and be working as part of a team. Oh, that's different. Okay, so scheduling the visit length to meet the patient need is like one piece of a bigger puzzle that has to be figured out when you start messing around with the schedule. Secondly, you could improve the referral and scheduling system, make it more rapid, so that behavioral health services are easier to access within the practice itself. So for example, if the patient's being referred to behavioral health provider, during a primary care provider visit, the patient doesn't leave without getting that first behavioral health visit put in place. And in fact, that might even be expedited by something called a warm handoff. Let's meet the behavioral health provider. I have someone I think can really help us with this long-term chronic problem that's been plaguing you and making it so difficult for you to have the life that you want to have. Let's go meet them now. And off you go, meet, schedule a visit. There you go. You've got that next visit already been met, already know who you're talking to, nice person, smiled at me. Yeah, I think I could do that. Rather than letting me decide, do I really want to do that or not? It sounds kind of weird. I don't usually do that. It's all taken care of. All right. Guide the team engagement in managing care. We're saying there's a team, but that doesn't necessarily mean it's easy to act as a team. A patient who has diabetes and a blood pressure issue and depression is going to need a couple of things. And you might need a protocol in order to say to the team, okay, here's how we're going to manage this. These are the resources we have. So when that patient comes in, there's an assessment of this kind, and there's tools like this, and there's patient education materials, and there's a conversation that uses motivational interviewing. How do we do that? Let's practice together. So there's a process for taking care of patients that the team can engage in while it's delivering care together and learning from each other. That's another kind of strategy. Another strategy is identifying patients in need. Like, not all patients need the same thing, right? So you need to know who your patients are. Who are your patients that have multiple chronic conditions? And how would you reach out to them rather than waiting them to come in and have a primary care visit, and then all of a sudden, oh, their blood pressure's out of control. Let's look for those patients who are most likely to need help and see if we can learn if they actually do need help. And then if they do need help, talk about helping them come into the practice. That's another kind of strategy. Fifth is reorganizing the work layout and the use of space. Don't hide that behavioral health provider, in a closet, although some have had to start work there, and I've known a few of those. Put the person actually right in the pathway of the primary care provider. There you are, I needed you. Let's come on down to my office and meet a patient. So there's lots that you can do to help it enable the interaction and the support of the teamwork that goes into integrating behavioral health. And then as a last measure, remember I talked about documentation is important, make the best use of that documentation system. It should be a documentation system that's designed for access by the entire team. There are some states that prohibit behavioral health providers putting their information into a medical record system. And of course, you have to follow state law. But the goal, at least putting down patient goals and shared plans so the entire team can work on that together, is critically important in order for there to be integrated care. That's a lot of strategies, and I'm not going to ask you to remember them, but we are going to look at one or two as an example for a case study so that we could talk about, well, what does that actually mean? So when you look at all these strategies together, you can see that they all have a common thread. They're all about building capacity and providing a care protocol that's tailored for population needs. We have limited resources in primary care already. We're adding a new kind of service, behavioral health. And the goal is not to add more work to people, but to split that work up in a team to relieve the primary care provider to be able to work as a team, but also to allow the behavioral health provider to do some of that work and to re-engage with the patient as part of the primary care relationship. Nothing is really more important than the relationship patients have with their providers, all their providers. And everything that we do should honor that relationship and support it in keeping with good medical practice and behavioral health practice, and also in keeping with taking good care of our team members. So that's what all these strategies are about. Now, which one shall we look at for this particular example? I propose, since I'm the one that made this presentation, that we look at two. There's a lot to choose from, and commonly picked examples were scheduling the first behavioral health visit before leaving the primary care provider, and having a roster of patients in the first place of those patients with multiple chronic conditions that could be used for outreach, so that you bring the patients in before they're in crisis, they talk to the primary care provider, and then before they leave, if in fact they need it, they schedule that first behavioral health visit. All right, so what does that look like? Well, remember I said first you go and you find what does it actually look like. So before using the toolkit, Practices typically had something like this. The patient with multiple chronic condition comes in for a visit. They were scheduled for a visit. They have multiple chronic conditions. They're always coming in. Great. Every 3 months, whatever it is. Or they don't. But let's say they do. And at that visit, the primary care provider says, I really think that behavioral health services would be helpful to you. Some of them leave the office and say, not doing that. Lost a follow-up. Don't include me on that. Some of them move forward and they are scheduled for a behavioral health visit, but after their schedules and their calendars, they go, yeah, I don't think so. And they don't show up. Some of them follow up on their scheduled visit and they arrive for the behavioral health visit. They have a visit and then they go, no, not for me. I'm not coming back. And then some continue on to ongoing visits, sometimes leaving, but sometimes going through to completed treatment. We call this a voltage drop with all of these loss to follow-ups. And this is dramatic. You can wind up starting with, if you had 100 patients here, you can wind up with like 30 patients here. It's very large. So you have this big, system of all this work and all of this loss taking place at the same time. How could it be different? Well, here's one practice's picture. We're going to identify patients with multiple chronic conditions from the roster, right? We know who they are already. We have a fully functional electronic health record system that can tell us what patients have what illnesses and issues. And we can pretty much say, well, let's start with the ones that have the most or the ones that are most severe. But we're going to pick a few and we're going to reach out to them and we're going to have a screening tool. And we're going to find out, are you depressed? Are you anxious? How's your blood pressure? Blah, blah, blah. What is it that we need to know about them? No fallout here. We call you, we say we want to talk with you. We're your doctor's office. We care about your health. We just want to ask you a few questions. Okay. So now you're positive on the screen. You're like, okay, you maybe need to come in. Your doctor would really like to see you. You have a visit scheduled in 2, 3, 4 months. Let's bring that up a little bit. We want to make sure that you're okay. Primary care provider visit happens. Okay, you're in to see your primary care provider. You see him or her all the time. And in this case, the visit happens to end with a WHO, warm handoff, and a scheduled visit. So now you're like, no loss to follow-up yet. You've got them and you didn't have to wait. You went for them and they came into you, and now you've got the possibility of ongoing behavioral health visits because now you've met the person and you scheduled the visit right when you were there. So will there be loss to follow-up? Yes, this still is true. This piece is still there. But you've already started seeing the person here. And so now what is the likelihood of you seeing patients there much higher in terms of completing treatment? So that's what we asked practices to consider. These were, as I said, 42 practices, 20 of them had the toolkit, 22 did not. And the way we measured success was by looking at how did their patients do? And their patients had surveys that we had a random sample from each practice of about 75 patients each practice, completing over a period of time, several times, validated 29-item nationally recognized survey. It had 2 global scores to cover physical health and mental health, and 8 domain scores of all of these different items that help identify how well this patient was doing. And in addition to that, we also asked practices to fill out surveys. This was called the practice integration profile. We were trying to measure how integrated the practice was. This is a validated 30-item online survey, had a summary score called the total PIP score, and 6 domains. Clinical services is how well the behavioral and medical providers worked with each other. That was integration. Clinical services, what were the different behavioral health services offered? Integration is how the behavioral health and medical health providers worked with each other. Engagement was how well the patients were brought in to be treated and followed up and how consistently that happened. Identification was finding those patients that needed care. Workspace was the physical arrangement of how you can organize the workspace in order to promote good integrated care. And workflow was kind of like the diagrams we were just looking at. How is our work organized so that we make sure we find the right patients, care for them in a timely way, and we don't lose them. There's a tool for this called the practiceintegrationprofile.com. And you're welcome to try it out sometime. It has a test version as well as a real version for practices. So these were two kind of outcomes, patient-reported outcomes and practice-reported outcomes. And to kind of summarize this as we move after top of the hour, so let me keep going here. We had 2,400 and more patients, or 82% complete outcome surveys over 2 years. This is stupendous. This is considered quite representative of the whole group. We found no significant differences in health status improvement. It looked like the toolkit group and the non-toolkit group were about the same. But then we looked inside the toolkit group and found that a good portion of those practices that had the toolkit didn't use the toolkit through implementation. Remember, I said you actually have to implement a change in order to see an outcome. And when we separated this group into those that implemented and those didn't, those practices that had implemented their changes had patients reporting significantly better improvements in mental health summary scores, as well as improvements in all domains. So structured toolkits can make a difference if you use them. It's kind of like medicine can make a difference if you take it off the shelf and use it. It's the same practice, the same principle. And in the same way, their practice reported outcomes, we had 42 practices, all of them complete the surveys over the whole year. In the larger study, control versus active, toolkit versus non-toolkit, only the workflow domain score improved significantly, so the toolkit made an impact. But when we looked again in those clinics in the intervention that actually used the toolkit through implementation, those that did so had significantly better improvements in total PIP with improvements in all domains. Again, if you implement your change, you can make a difference in terms of outcomes. You truly can move the dot. Even if you're working in a busy primary care practice that's trying to integrate care, survive COVID and everything else. This was a COVID-based study. We started it before COVID happened. Of course, we didn't know COVID was going to happen. And even the impact of COVID showed these changes were possible. So it was a good study. All right. And we also found out other cool things, like we found that the higher the PIP the practice had, the more integrated the practice was, the higher the scores for patients. So that's across all practices. So we found that integrated care is associated with healthier patients, both at baseline, the beginning of the study, and at the end. That was cool too. I have to put that in. All right. We also learned that there are reasons why you can support doing implementation. You know, you've got a toolkit, you want to make a change, or you just want to change integrated care and you don't have a toolkit. We did qualitative research on 8 of these study sites, 82 interviews, and we found that really, if you don't have leadership's commitment to making a significant change, it's not going to happen. You need to have leaders, and you will become leaders, you all. Like, don't think, oh, that won't be me. Yes, it will be you. You'll be thinking about, how do we make things like this happen? And one of those pieces is the role you have as a leader, wherever you are in an organization that you work with. Financial considerations. We live in a market-based economy. Therefore, you have to be able to pay people salaries. So you must be able to bring in money. You have to figure out, how does this work financially in order for you to be able to make change stick in the United States. You have to plan workflow changes, very much as I just indicated, and communicate effectively throughout that workflow change process so that everybody's connected together. And you have to help your providers and other healthcare teammates share perspectives on integration. That vision piece at the very beginning, long ago, I said, planning is important. You have to have a shared vision. That shared vision sticks through the entire process and keeps the team together. All right. So there you have it. I'm going to go back to the one slide that I said covers everything in this entire overview, which is that, yes, there are many challenges. That includes many patients with multiple chronic conditions, of which there will be more in the future because we're all getting older, not younger, coupled with stress-inducing systems such as what we've just been experiencing, changes in work role, COVID-19, whatever comes next, and burnout. So there's a lot of challenges. Yes, there are, but there's a lot of strategies for building capacity and tailoring protocols for population-specific needs. We can deliver to these. We just have to take the time to think about it and plan it out. And the time to do that can be managed through structured team-based methods, so that you can do something like schedule the first visit as part of a primary care visit. and have a roster of patients so you know who you're looking for when they come in the door so that you can help them get the care they need. All right. That's the lecture or conversation or discussion. And in a couple of minutes, I'm going to shut up so you can all ask me questions or talk to each other or plan your next day. But while you're planning your next day, I want you to think about tomorrow, November 3rd, 2022. Not that big a deal. Just another normal Thursday, right? Well, actually, I want you to do something. In order to begin to make these kinds of changes as students, especially as students, like this is your job, you ask an unscripted question, make a connection, think about something, send Emily an email, send me an email, but ask something you haven't asked before. One of your most important assets as a scientist and as a health science worker is to be curious. And your curiosity can be formed into questions that haven't been asked before that you can say, oh, we could do this differently. Oh, we could do this differently. And as students, you're in the perfect, safest, most beautiful place to do that. Just enjoy being a student. It's the best thing ever. Count something. Remember I said you have to measure it at baseline or you won't know that it makes a difference. Count something that's important to you, please. Change starts with learning what you're doing now. So just keeping track of something, weathermen to keep track of the weather, you can keep track of something too, something that you care about, and then you'll learn something about it. Write something. Not everybody loves to write, but blogging is a thing, a letter is a thing. Professional papers are lovely. They take a while, but you write papers and you can do that, but you can also write haiku. I mean, it doesn't matter what you write, just communicate what you've learned, because then other people can begin to make those connections and work with you on it. And lastly, find consensus. You can't do anything by yourself. You have to work with groups of people that want to move change. In this world, we need a lot of change of all kinds. So what's the next change that will move us forward? So these are the things to do in order to make the beginnings of healthcare systems change, and the use of a structured toolkit. You have to have an interest in something, be curious, collect data, write about it, share it. All right, most of all, you have to keep your balance. You're students, you're busy, you have a lot of work to do. This is a semester, you want to get through it. I know you will. You're important and you're going to be part of the future of healthcare. So don't give up, don't give in, don't give out. Make sure that you can keep on doing it, keep your balance. And just remember that the tools that I shared with you give us all hope that we can make the system better, not just for our patients, but for ourselves too. Here's your final picture of the evening. So people in a line, they're looking for answers. There are two kinds, simple, but wrong. Oh, short cliff, skeleton. Okay. Complex, but right. Oh, asking questions, counting, writing, talking to colleagues. You'll get there. Okay. Remember, there's simple, but wrong. There's complex, but right. This looks like a more productive path, although it is longer than this one over here. Not to be threatening or anything, but I'm really glad you're students and you're learning, because that will really help you. I want to acknowledge the hundreds of people that were on the integrated care team. There were many, 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 and they did fabulous work. And they were a wonderful team and took us a lifetime to put together, it felt like, but our work is at least completed and we're getting started on the next set of projects. So again, a thank you to Emily, a thank you to you all. I've got plenty of references if you ever wanted to read more material on this, but I'd be perfectly happy to answer questions or comments you have, or if you are done, to let you all go. And I see there's some stuff in the chat. Oh, my background in education, I see from James, and then I'll work backwards. My background in education was I have a BA in philosophy and in economics. I have an MBA, a Master's in Business Administration. I also got a Master's in Health Services Administration. The University of Michigan was doing a 2 for the price of 1.5, so I got them kind of overlapping at the same time. Then I did about 25 years in healthcare administration, analysts, decision support, all kinds of stuff. I went back to school, got my doctorate in public health at the University of North Carolina, and decided that I loved healthcare so much that I was going to just immerse myself into how can we make this system work better for everybody. So anyway, and if you have more questions, James, I'd be glad to answer them about that. And Joanna Keefe said, in Massachusetts, people have been on pain meds for most of their life due to very bad accidents. The pain, oh, I see, in Mass. Oh, the pain will be with them for the rest of their lives. Are now, in Massachusetts, are being put on Suboxone instead, which I find not to be a strategy, but leading into another issue. They are not asking patients, they are just telling them. Yeah. There's a certain amount of desperation among providers who have been trying so hard to help patients who are on pain. Pain is super debilitating, as you know. It's got lifelong consequences. It leads to supports that limit your life as opposed to extend your life. And now there are, and so providers are looking for solutions. It is hard to do this well. One of the benefits I've had in my work is, and I mentioned this before, remember there was this beautiful picture of a spider web. And one of the benefits I've had is doing research and work with patient partners who help us as providers and as researchers figure out how to talk to patients, engage patients, and do that in a way that doesn't destroy our workflow, but actually makes it better. And we're learning. We're learning. But that's a good point, Joanna Keefe. Thank you very much.
Well, thanks, Connie. We're just at the end here. I want to be conscious of everybody's time, but I certainly appreciate this great presentation. If anybody has more questions and want to stay on, we'll hang out for a minute. So thanks, everybody. I'll see you next week back in Bentley. See you then.